I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Welcome to the Not Your Mother's Menopause podcast. Thanks for tuning in. I'm Dr. Fiona Lovely, and today I'm having a conversation with someone near and dear to my heart, but also to the show, Dr. Jenn Simmons. This is Dr. Simmons' third appearance on the Not Your Mother's Menopause podcast, and she did not fail to blow my mind as she always does. Right away, we're into it. We're digging deep, and she is spilling the tea, so to speak, on what is going on in the women's health industry related to breast health, breast disease, and certainly breast cancer. So get ready. Because here we go. We've already agreed to meet next year in September for Pink Month, shall we say. So episode 4 will be incoming. If you have questions you'd like me to ask Dr. Jenn, please, as she invited you to message her on Instagram or send me a message and I'll make sure to put it on the list for next year. So Dr. Simmons is a breast surgeon, integrative oncologist, 3 times author, podcast host, 3 times summit host, and the founder of Perfection Imaging. Perfection is spelled Perfeqtion. Dr. Jenn Simmons started her professional career as Philadelphia's first fellowship-trained breast surgeon and spent 17 years as Philadelphia's top breast surgeon. Her own illness led her to discover functional medicine. So enamored with the concept of creating health rather than killing disease, she left traditional medicine in 2019 and founded Real Health MD to help women along their breast cancer journey truly heal. Dr. Jenn is on a mission to change the impact of breast cancer by empowering millions of women to take control of their health and create the life they want. She hosts her weekly podcast, Keeping Abreast with Dr. Jenn, hosted the Breast Cancer Breakthrough Summit, and is the author of The Smart Woman's Guide to Breast Cancer and Recipes for Real Health. Dr. Jenn is currently opening Perfection Imaging centers across the country, featuring QT imaging, an innovative technology that uses sound waves to create a 3D reconstruction of the breast without pain, compression, or radiation. This fast, affordable, FDA-approved technology has 40 times the resolution of MRI and will forever change the way that we screen for breast cancer. We've talked about a lot of things, Dr. Jenn and I, in the 3 episodes we've done. And in this episode, she talks to us about how mammograms became the standard for breast screening, how they should not have continued to be the standard based on the science, based on the research. And yet the industry is so massive at this point that it's difficult to say, well, maybe we should do it a different way, or, oh, oops, maybe we shouldn't be doing it at all. So if that sounds irresponsible, if that sounds like I'm pushing buttons for you, then please listen to the episode. Dr. Jenn explains all of this. And if we're not doing mammograms, what we should do instead. One of the things I am most hopeful about that she shared in this episode is the discussion around ductal carcinoma in situ, or DCIS, which is not breast cancer, but is treated like breast cancer. So again, just keep in mind, if you're hearing this and you're triggered by what I'm saying, please just listen to the episode and let Dr. Jenn explain. It's tough when you've had a diagnosis of your own and you've come to find out that maybe you didn't have all the information and that you weren't given all the information and that you didn't know there were options. So, sister, I got you. We're going to share in this episode what you need to take care of breast health long term. I think, as always, Dr. Jenn shares things that are shocking and surprising, and why aren't they common knowledge? And, we got to keep this conversation going, because pink washing is a real thing, and we are in the month of October. So buckle up, sisters. You're in for a fun ride, as always, with the illustrious, highly intelligent, and lovely Dr. Jenn Simmons. Well, I am so excited to have a friend of the show back today, Dr. Jenn Simmons, integrative oncologist, functional medicine guru, and breast surgeon. This is time number 3. Welcome back to the show.
Thank you. I'm so happy to be here. So happy to see a friendly face.
Yes, indeed. And same. There's so much for us to talk about, but I just want to say thank you for coming back on the show every fall for the last 3 years. You literally are, as I say to my assistant, the signal that we're starting a new season of the show.
All right. I like that.
And the most questions I get in person from my patients about guests on the show come about the conversations that you and I have had, and they want to know more about you and what things you have to share.
Okay. Well, I hope that's a good thing.
It is. They love it because, of course, now you and I talk in this way all the time, but what we talk about is a little bit of shit disturbing. I think you know this.
Yeah. It's quite provocative. Mm-hmm. And yeah, I'm definitely making waves these days.
Yeah. So what's the update?
Yeah. The funny thing is, what I talk about isn't new and the data isn't new, but every year it seems to just stir things up. So as we start the month of October, which, is usually when you and I have our conversations, and all around the world we talk about breast health awareness, but I feel like it's so much Groundhog Day where it's the same thing over and over and over again. Go get your mammogram, right? And that is perhaps the very best pink washing campaign that has ever been. I was having a conversation with Donna Pinto yesterday. I don't know. Do you know Donna?
I don't. Should I?
You should. I think she would be a great person for your podcast. She is just a regular, normal person who, I might get my dates a little off, but maybe in 2014 was diagnosed with DCIS and essentially told that she needed to have a mastectomy. I think probably the urgency with which they treated her and the extremism with which they treated her made her more or less question whether or not that was the right advice, good advice, sound advice. Why was it such an emergency? And she ended up just being a huge advocate for women with DCIS, or ductal carcinoma in situ. And as a result, has gotten really fundamentally involved in the clinical trials, in looking at overdiagnosis and kind of the root of overdiagnosis is the mammogram. We really haven't done anything in the last 50 years but put more lipstick on that pig.
Ooh, girl.
I mean, for all intents and purposes, that's all we've done. And we've taken the data that we've had for 50 years and we've suppressed it and we've manipulated it and we've restated it in ways that people don't understand what it means. But, this whole concept that mammograms save lives is the biggest lie that's ever been perpetuated. Well, maybe the second biggest lie. I don't know. whatever. They're neck and neck. The lies that we were told in 2021 and this lie are probably equal.
Yes.
And, the thing is, and what it comes down to, and I like to refer back to Dr. Michael Baum. And I don't know if you know who he is, but he is a surgeon in the UK. And he's probably in his 80s by now. So he was actually fundamentally involved in rolling out the mammographic screening program in the UK. And he actually owned and ran breast imaging centers that utilized mammography, because I think the first clinical trials, which were in the early 1970s or late 1960s, showed a 30% increase in survival with mammogram. And that was kind of all he needed to see. And he advocated for it and was smart enough and powerful enough and influential enough that it took hold. And then in the late 1970s, in a follow-up study looking at that original data, they were like, hang on a minute, because we don't know that these studies were so good. And what was determined, and this was in 1977, what was determined is there's actually no increase in survival when you screen with mammogram. And in fact, when you use mammogram to screen and create this whole syndrome of overdiagnosis, you're actually costing lives, because you're taking women who would have never been diagnosed with the disease in their lifetime.
The AG1 you've all heard me talking about for so long just went through a major upgrade. AG1's next gen is here. It's the same single scoop once a day, but now it's clinically backed and formulated with more upgraded vitamins, minerals, and probiotics. The new next gen formula offers a more advanced, clinically backed formula that fills common nutrient gaps and supports gut health, all in the same easy once a day ritual. AG1 has been a game changer for my mornings. It sets the tone for my day, helps me feel my best, and like I'm taking care of my nutrient needs in one step. AG1's next gen includes 5 clinically studied probiotics and additional vitamins and minerals to support whole body health. Now clinically backed with an advanced formula, this is the perfect time to try AG1 if you haven't yet. I've been drinking AG1 daily for 6 years now, and I'm so happy to be partnering with them. Subscribe today and try the next gen of AG1. If you use my link, you'll also get a free bottle of AG D3K2, that's vitamin D3K2, an AG1 welcome kit, and 5 of the upgraded AG1 travel packs with your first order. So make sure to check out drinkag1.com. That's drinkag1.com/Fiona Lovely to get started with AG1's next gen and notice the benefits for yourself. That's drinkag1.com/Fiona Lovely.
They would die with the disease, not of the disease, right? It would never become clinically relevant. You would never have developed a lump. It would have just been a microscopic finding that if we autopsied every single woman that died, we know that at least 1 in 5 will have evidence of breast cancer, not clinical evidence of breast cancer, just microscopic evidence of breast cancer. So when he determined this in 1977, he was like, wait, we gotta turn this ship around. But by then, by the 1980s, it had already taken stronghold. And what it became is a matter of like self-righteousness, and it became religion, and science was just thrown out the window. So no one cared about the data that showed that there was no increase in survival, and no one cared about the overdiagnosis, because the bill that they were sold, the story that they were told, the narrative was that we cured the mammogram finding your lesion, cured you of breast cancer. And what's actually happening still today is that we're thanking the person from saving us from being hit by the train, but that person is the person that threw us on the tracks, right? We are thanking our captor.
Wow.
And that's what it is. And it's become this, like, it's more virtue signaling.
Yes.
That's what it is. It's just another pinkwashing campaign and virtue signaling where, all of these products that they put out in October, and the mammogram is included, and they slap a pink ribbon on it and say that they're donating to this foundation or that foundation. And maybe they are. But if all that foundation does is pay for mammograms, you haven't helped anyone, you haven't saved anything, but you feel better about it because they're donating to a charity. Or even worse, they slap a pink ribbon on something that actually causes breast cancer, that contributes to breast cancer. And now you're donating to you're increasing the consumption of toxic things. You're increasing the support for companies that make toxic things. And then you're donating to charities that support the perpetuation of this very, very broken system. And so I'll say again that, the number one thing that we can do tomorrow to decrease the incidence of breast cancer is we can stop screening with mammogram. Now, people think that's heresy, right? That people are going to die. It's not true. No one's going to die. But they think that people are going to die. And they also take that from me saying we shouldn't screen, which is absolutely false. I'm not saying we shouldn't screen. I'm saying that we need to be in touch with ourselves. So we need to start doing self-breast examinations, because I know that we were discouraged from doing that, because why on earth would they want us to be in touch with our own bodies so that we can recognize when something's changed, right? So we're discouraged from doing self-breast examinations. And on top of that, there are 100% safe and effective ways to screen for breast cancer, which we are ignoring because they don't have as much data as mammogram, right? So we're pretending that there's nothing new under the sun, and we are putting this very broken technology up on a pedestal that it doesn't deserve, right? We're not looking around. We're not opening our eyes. We're not entertaining the possibility that there's something else. And there is.
Yes.
There's lots of something else. So the first thing that is new that I think everyone should know about is the ARIA test. Have you heard of this TEARS test?
I have not.
Oh my God. See, this drives me crazy that people don't know about it. So this is a test that is the company that discovered this test, the lab is called NAMIDA, NAMIDA. And what they discovered is that there are two proteins, the S100A8 and S100A9 proteins. These are inflammatory proteins. Individually, they are associated with other things like inflammatory bowel disease. And when you see those two proteins bound together, it's something called calprotectin. I'm sure you've heard of calprotectin. And calprotectin is something that we measure to see when there's inflammation in the gut. And that's generally associated with inflammatory bowel disease. So Crohn's, ulcerative colitis, that kind of thing. So, but when these proteins are elevated as the isomers, as the separate proteins, and they're both at critical levels, this is highly, highly linked to early stage breast cancer. So in a very simple test where you just put a little tiny piece of litmus paper underneath your lid, close your eye for 5 minutes, take this litmus paper out, put it in a little tube, and send it off to the company. And a week and a half later, you have this result, and it's either clinically significant or normal. So this test, which is an at-home test, it's very inexpensive. And in a couple of minutes, you can find out if you are at risk for breast cancer right now. And it has nothing to do with genetics. So it is a real-time risk assessment. And it's something that I recommend people do every single year. And I use it to determine who does and who does not need imaging. It has a 93% sensitivity. So way better than any mammogram, better than ultrasound, better than QT, which is the imaging that I advocate for. The only thing that has more sensitivity is MRI. But MRI, I mean, it's expensive. It uses gadolinium. If you don't use gadolinium, it's useless. So you're putting a heavy metal in your body. They're uncomfortable. There's access issues. Like there's a lot of reasons to not screen with MRI. But this test is a 58% sensitivity and it has a 58% specificity, meaning that 42% of the time, when you have a clinically significant result, you do not have clinical evidence of breast cancer. Now, some people say that that's a really high false positive rate, but I will tell you that there are no false positives with this test because it's not a test for whether or not you have breast cancer. Mm-hmm. It's a test for whether or not you have the inflammatory precursors to breast cancer. Mm-hmm. And what this test is, as far as I'm concerned, is opportunity. Because you now have the knowledge that you are at significant increased risk for breast cancer. What are you going to do about it? Mm-hmm. So I recently had Dr. Jack Wolfson on my podcast, the Keeping Abreast with Dr. Jenn podcast. Mm-hmm. He is the natural heart doctor or something.
Love him.
I think that's his tagline.
He's married to a chiropractor, by the way.
Yeah.
Yeah.
And she's the whole reason that he's the natural heart doctor.
Yeah, it's quite a story, isn't it?
I mean, his story is amazing.
Yes.
Her story is amazing.
Amazing, yes.
She opened his eyes to a perspective that he would have never had because his father was a cardiologist and he was just falling in line. I mean, he graduated and trained and went to work for a very conventional cardiology practice, right? And after 20 years, he was like, what am I doing? Mm-hmm. I know so much better. What am I doing?
Yeah. Didn't you have the same wake up?
Test after test.
Didn't you have the same wake up?
Yeah. Well, I had a wake up because I got diagnosed with thyroid cancer.
Yes.
So,
yes.
My wake up was, what do you mean that I need surgery and chemo and radiation? Mm-hmm. Like, you can't be talking about me. That can't be right. Yeah. Right. And surely there has to be something better than the thing that I've been telling everyone all day, every day to do. Right. Mm-hmm. Mm-hmm. Because when it's about you, it's different.
Oh, yeah. Yeah.
But for him, I mean, by the grace of God, his marriage was the thing that showed him that there was a different way. And what he said, which makes so much sense, is that, instead of going to do all these tests that literally increase your risk of the disease. Now, he, in fact, was talking about the cardiac calcium score because he said, I don't send people for a cardiac calcium score anymore. I just say, if you're willing to go and do the test, what are you going to do with the results? Because you should never take a test that you're not going to do anything with the results. And if the results are positive, if you fail the test, what are you going to do? And he said, just act like you failed the test. Do what you would do if you failed the test. Mm-hmm. And that's my perspective too. If we talked about prevention, a fraction of the time that we talk about getting a mammogram, getting a cardiac calcium score, getting a nuclear medicine scan, getting all of these screening tests, let's just talk about what we would do if we would fail the test. Because if you live your life like you failed the test, you know what you're not going to do? You're not going to fail the test. That's right. Prevention. Mm-hmm. Right? Mm-hmm. And so we need to be talking about prevention. We don't need to be talking about sending people for these tests. in your life, the more mammograms you have, the higher the likelihood is that you're going to be diagnosed with breast cancer. What are you going to do about it?
Yeah.
Live your life like you failed the test.
Like you failed the test. I love that. Okay. There's some things I got to unpack before we get too much farther down this conversation. So much information already. Thank you. I want to come back to one of the first things you talked about, which I think if I break it down to the simplest terms for whoever is listening, is if you keep looking, you're eventually going to find something. But do we need to be treating everything that we find?
So it's really interesting that there hasn't been a test yet that can distinguish between who we should and who we should not treat.
Yes.
Now, listen, has that test been invented? Probably.
Mm-hmm.
Will that test ever see the light of day? I highly doubt it.
Mm-mm.
I highly doubt it, because who benefits from that?
Mm-hmm.
Right?
The women
There's
do.
no one in industry right now that benefits from that, because the imagers don't want it, because they make a lot of money on doing these images, procedures, biopsies, bring them back afterwards, follow up. Like, there's no benefit to them if we have a test that says this is nothing, it doesn't need to be treated, right?
Mm-hmm.
And then the hospitals certainly don't want it, because, for every DCIS patient, they make $66,000. For invasive cancer, it's probably double that. So, we diagnosed 90,000 women last year with DCIS.
Which is not even cancer, is my understanding.
No, of course it's not cancer, but they treat it like it's cancer, because only 20% of DCIS will go on to become invasive cancer. And if we could identify that 20%, it would make people feel a whole lot better to know who does and who doesn't need treatment. But there is no test, because there's never going to be a test, because the industry won't allow for it. And so 100% of them get treated, even though they don't need it, unless they are the very small contingency of them that they're awake and they're educated and they have enough intuition to question the diagnosis, to question the system, to take the time to educate themselves. I mean, that's why I wrote my book, The Smart Woman's Guide to Breast Cancer, because I wanted people to know, even if you have invasive cancer, with very rare exception, if you have inflammatory breast cancer, that's an emergency. If you have metastasis to a bone that caused a fracture, that's an emergency, because they're terribly, terribly painful and it's impossible to heal when you're in pain. If you have brain mets, that's an emergency. But if you don't have one of those three things, you know what you have? You have time.
Time, yes.
You have time and space.
Powerful.
Breathe. Educate yourself. Read my book.
Please, everybody read it. Even if you
don't have a diagnosis,
please
you should read my book.
It's so useful. It's a wonderful reference guide for women's health. Thank you for writing it.
Yeah, of course. I mean, that's why I wrote it, because right now women are not able to make an informed decision because they don't have the information. How do you make an informed decision if you don't have the information? And it's intentionally not given to them. They are so rushed to treatment, because if you take the time to learn and to educate yourself, you might say no. And they don't want you to say no. They want you to say yes. They want to get you in the operating room. They want to get you in that radiation suite. They want to get you on those meds. And those meds create customers for life, because most of those medicines, when women, once they become postmenopausal, they get put on a group of drugs called the aromatase inhibitors. So the aromatase inhibitors are acting as medicines to shut down our estrogen factories, right? And so we cannot produce estrogen while we're on these drugs. They use it for hormone positive breast cancers, which about 70 to 80% of breast cancers are hormone positive, which doesn't mean that your hormones cause breast cancer. They don't. It's a ridiculous, ridiculous statement. And so when you put women in this state of estrogen deprivation, they develop a lot of problems. They develop cardiovascular disease, they develop cardiomyopathies, they develop neurodegenerative disease, they develop osteoporosis, they develop joint disease, they gain weight, they lose their ability to hold their urine, they lose sexuality, they lose sensuality, they become depressed, they can't sleep, they're anxious. Well, guess what? We've got a drug for that. And all of those drugs for that suck. And one pharmaceutical leads to the next pharmaceutical, leads to the next pharmaceutical, leads to the next pharmaceutical.
And for the woman listening to you say that, tell us again the abbreviated version of your story. Why are you qualified to say these things, please?
Well, I mean, besides the fact that I went to medical school and did residency and did fellowship, and I'm a fellowship trained breast surgeon who treated breast cancer in that conventional medical world for 20 years. And then when I had my own diagnosis, refused conventional treatment because it was the first opportunity for me to say, well, you know, why did this happen? To get to be on the receiving end of, oh, it just happens and there's nothing that you could have done to prevent it and there's nothing that you can do to reverse it. And it just, because mine was the thyroid gland, and when you take the thyroid gland out, you literally cannot survive without it. And so for me, in my head, I was thinking, why on earth would God give me something that I needed to survive only for me to remove it and rely on lifelong replacement that I literally won't survive unless I take this synthetic replacement? Like, it just didn't make sense to me on any level. And we're doing the same thing to women who get breast cancer. We are essentially castrating them, right? Yeah. So when this happened to me, I went looking for answers. And so I kind of, I believe that it was divine intervention and that God put me in a place where I happened to be sitting in this lecture hall. Like I was just looking for answers, grasping at straws. And I'm sitting in this lecture hall and this tall, lanky guy walks on the stage and he introduces himself as a functional medicine physician. Now, at this point, when I was diagnosed, I had been a physician for about 20 years. So I'm like, there's no such thing as a functional medicine physician. Like, what is this quack talking about?
Yep.
But then I realized that I'm sick and I'm there for a reason. So I check my big fat ego at the door and I tune in. And about 2 minutes later, I completely realize why I'm there and why I got sick. I got sick so I could be in that room on that day listening to this man speak. Because first of all, the man is Mark Hyman, who is arguably, he's the figurehead of the functional medicine movement. He's not the founder. Jeffrey Bland is, without question, the founder. But he is, by all intents and purposes, the figurehead. And what he says to me, just blows my mind. Because he's talking about medicine in a way that I had never thought about it before. And here I am, a cancer doctor dealing with my own diagnosis, and he's up there saying, yeah, all you're focused on is the tumor, but the tumor's not the problem. The tumor's the symptom of the problem. And unless you back up 10 steps and figure out why that tumor is there, What's going to change for you? Nothing's going to change. What's going to stop the tumor from coming back? Or what's going to stop the next manifestation of your dysfunction? Because cancer is a normal response to an abnormal environment. And unless you're asking what is abnormal about the environment, you're never going to make any progress. You're never going to be healthy and well. But healthy and well is not the goal of our current system. The goal of our current system is sickness and dysfunction. Because the only way that you can get into the system is to fail the test. That's it. That's the only way you get into the system. And our providers are not trained to make you healthy.
No.
It may be their philosophical goal, but it is not their practical goal. They are not trained to do it. They don't know how to do it. And a really good doctor or a really good provider knows how to recognize symptoms, give it a name, give it a diagnosis, and prescribe. Right? That is how you are a really good doctor in this system. And those are the doctors that are rewarded. The ones that prescribe the most, the ones that order the most tests, those are the ones that are rewarded in the current system.
Wow.
And there's no reward for your patients being healthy. First of all, if your patients are healthy, they're not coming in to see you. A doctor literally can't make a living with a healthy patient population because they're not coming to see the doctor. Right? They're only coming when they're sick or when they're not getting paid for well visits.
No. And I had a mentor in school who said to me, I love this, one of my best bits of practice information I ever got was, she said, act as a doctor as if you're trying to put yourself out of business. Do the best job for the patient in as little time as possible. And of course, that flies in the face of what you would think about practice building and all of that sort of thing. But I tell you, 20 years in, that has served me right from day one. And I still hold that in high regard.
That philosophy is amazing. And I love it. The problem is doctors don't know. They don't know how to help their people. They say if you're overweight or you start to develop some metabolic dysfunction, eat less and exercise more, right? But everyone knows eat less and exercise more. And we're getting more and more obese and having more and more metabolic dysfunction. So, it's not that.
Yeah.
Right. And so when we go back to the initial question of what makes me qualified is that, I had this amazing enlightenment that day with Mark Hyman, and I immediately, now granted, I get very excited and I'm an early adopter. I'm a quick start, right? So I'm on my phone looking up the Institute for Functional Medicine because he was head of the Institute for Functional Medicine at the time. And I'm like, okay, what do I do? How do I sign up? And that day, I literally enrolled in the Institute for Functional Medicine and spent the next 3 years of my life just immersed in the study of functional medicine. And I came out on the other side of it. I mean, thank God, right? It took me 3 years to heal myself, but I did. And came out on the other side of it knowing that I couldn't stay in that same system. Because not only did I make foundational changes in my own life, because I thought I was healthy, just like everyone who walks into my office with a breast cancer diagnosis says, I'm healthy, but I have breast cancer, right? Because we don't know what healthy is and we don't know what healthy means. And I was no different. As a 20-some year physician, I didn't know what healthy meant. I thought because I could play 3 or 4 hours of tennis a day because I wasn't overweight, I thought I was healthy. And little did I know that I wasn't. I wasn't anything like healthy. And so I enroll in the Institute for Functional Medicine. I learn all of this. I get certified. I come back and I just know that there is no room in the conventional medical world for functional medicine, at least as a surgeon. At least as a surgeon. Because the truth is that in the functional medicine world, we spend a tremendous amount of time with our patients. And my hospital was paying me to operate. Wasn't paying me to talk to people about how and what and when they eat and how they sleep and how they move and how they think and how they connect and how they manage their stress and their toxins and detoxification. Like, no.
It's a lot. Yeah, it's a lot.
No. They want me to say, hey, that wound looks good. Let me do this biopsy. You need to be booked for the OR. They give me 15 minutes with a patient, including the ones that I have to tell that they have a new breast cancer diagnosis, right? And so there's just no room for it. There's no room for it. And I also learned that there are a lot of people that don't want it. There are a lot of people that don't want to help themselves. They just want the pill or the knife or the whatever, right?
Because they think they're cured. They're cured when
they're cured and they don't have to do the work.
Yes.
Because being healthy is hard.
It is hard. Yep.
Being sick is hard.
Yes.
You have to choose your heart. Right?
Yeah.
And we just finished this time in the Jewish year where we're very, very, very highly contemplative of how we have spent the last year. And we're talking to God about how we're going to spend the next upcoming year and asking God, can you give me another year to get it done? Right. And we talk about the fact that life is very hard. It's very hard. And we think that we should pray for life to be easy. But the truth is that the things that come easily to you, they don't feel so good, right? It's not so rewarding. And the people that struggle the most, I think, with their self-esteem, with their, true health, are those that they don't have a lot of purpose. They don't accomplish a lot. Because the people that work hard and accomplish, they're filled with a tremendous sense of self. And so I know being healthy is hard. I struggle with it every single day. My grandmother was, God bless her, by the time she was my age, she had already had 2 heart attacks.
Yeah, wow.
Right? And both of my grandfathers died in their 60s. Like, I know being healthy is hard. I have terrible, terrible, terrible genetics. But I can overcome that. It's my choice. It's not easy. I don't get to participate in all the birthday cakes and the pastas and the this and the that, right? Like, it's just, I know that I have to make choices every single day to support my health. And it's hard. But it's the hard that makes it good.
I'm so touched by your words about asking God for another year. That's so touching.
Yeah.
And humbling.
Yeah. And, it's in the Jewish faith, we very much believe in the afterlife, but you can't live this life in a cavalier way, just knowing that, there will be a better eternal place. You very much have to earn your spot in the next world. And we say, like, you would never go to the final exam without studying. And so God gives us tests every single year. And it's mostly like a check-in. Like, are you doing the work in between so that you can ace the final? And so it's our ability to check in with ourselves every single year and saying, are we living our purpose? And I think that's a really hard question for a lot of people. But we talk about there is increased survival in the cancer population when people are living in a purpose-driven way. And I know that everyone was put on this earth with some unique purpose, and no one is more important than the other. So my purpose, of course, is very big and very, very great. But that's my purpose. And that's because God knows that I'm capable of doing it. It's also a really hard job. And I make enemies every single day because I say things that make a lot of people feel uncomfortable. Right? And I get called horrible names and people say horrible things about me. And that's okay because I'm on a mission from God and my mission isn't supposed to be easy. Right?
Yeah.
But lots of people, maybe you aren't on such a big mission, and that's okay too, because God put you here with great intention as well. Everyone is here with their own unique purpose. And so when people ask, well, how do I know what my purpose is? My purpose, Dr. Jenn Simmons' purpose, is very obvious. But maybe for someone else, their purpose isn't so obvious. And so someone very, very much smarter than me said, think about the thing that you do that really lights you up, right? This is from Rebbitzin Lori Plotnick. She said, think about the thing that you do that really lights you up, that when you do it, you just feel so happy, important, inspired, right? It just gives you a sense of joy. At the base of that is your purpose. That's what it is. And so whatever your purpose is, do that. Do that.
Yeah. Yes.
Dedicate yourself to that. But every year we're checking in because your purpose changes. If you asked me 20 years ago what my purpose was,
different,
it was
very
to be
different.
The very best breast surgeon that I could be.
Yeah.
Right?
Yeah.
And then I got sick because that was not my purpose. My purpose was something much different and much greater.
Yes.
Right? My purpose was to forever change how we diagnose, how we treat, and how we screen for breast cancer. And I would have never known that. I would have never had my eyes open to that had I not gotten my own diagnosis.
Yeah, let's talk about that. I have literally my guides are chomping at the bit around me to share this story. So this will be the first time I have shared this story on the podcast, but I have a feeling you will have something to relate to here. So I have a thyroid nodule that we've been watching for years. Okay. So I've been through the yearly ultrasound screening, the biopsy that says we don't know what it is. But we're going to refer you to the thyroid surgeon. Okay. So I go see the surgeon. Now, I have gone and done my research on her, and I can see what her body of research is. I've read all of her papers. I'm pretty sure I'm the only one that's ever showed up in her office saying that I've read all her papers, because she does radio frequency ablation as treatment for nodules. And again, we need young women stepping in to research to figure out how to do this in a non-invasive way. Now, I go into that office. I see the intern first. The intern says, nice to meet you. I see you have nodules. Okay, so we do a thyroidectomy for that. And this is what the surgery looks like. This is literally how it goes. This is what the surgery looks like. Everybody wants to know about recovery. I literally put my hand up. I couldn't believe what I was hearing. Okay. I put my hand up and I said, stop. I am not having a thyroidectomy. And he paused. Again, he's a young man. He is learning how to be a doctor. He stopped and he said, well, I think we need to bring the surgeon in then. Got up and he got the surgeon, and she came in, again, a young woman. And she said, my intern tells me you're not interested in having the thyroidectomy. And I said, well, you guys need to tell me why I would be taking out a perfectly good thyroid. When on the back end of it, as a functional medicine practitioner, I have been working with these women for 20 years that had a thyroidectomy, even a hemithyroidectomy, and cannot control headaches, metabolism, heavy bleeding. It's terrible.
Awful.
Synthroid is not a viable option. It's the best we have, but It's not good enough. And I just get so fired up about this. So I as I hear you tell me what kind of cancer you experienced. So I just had a follow-up. That was 7 months ago. I just had a follow-up ultrasound. It has not grown because I'm doing the work. I'm working hard every day to make sure that I'm checking the box. I'm acting as if someone has said to me, thyroidectomy is happening in 6 months. Fiona, get your head out of your ass and get it sorted out.
Yeah.
That's
you have to live your life like you failed the test. So you don't fail the test.
Yes. Now, what I heard you say at the beginning of this conversation is that we're doing the same thing to women with breast disease.
Mm-hmm.
Whoa.
Yeah.
Let's discuss.
Yeah. Well, I first want to say about the thyroid is breast disease, thyroid disease, high blood pressure, prostate cancer, elevated lipids, all of these states are being overdiagnosed now. And I don't know if did you read the book by Dr. Gilbert Welch?
No.
Called Overdiagnosed?
No, but I'm on it.
Yeah, you need to read that. I mean, I don't think that anything in that book is going to surprise you, but it just kind of shines a big bright light on what we're doing with all of these states. And that's that we keep lowering the threshold for treatment. We keep lowering the threshold for when you get your sign, right? Your sign, that diagnosis, like here's your sign. Now go get in line for the treatments, right? So in the case of thyroid, we're just so quick to call it thyroid cancer because once we give people the sign, then they go get in line and they get a thyroidectomy and then they're a lifelong customer. They are a lifelong customer.
Yes.
You never lose them. And they become a customer of a lot of things, right? Because you talked about all of the dysfunction that goes along with
can't sleep, heavy bleeding. Yeah,
all of it. Yep. Right? So it leads to more surgeries. And, one of the risk factors for breast cancer is being hypothermic, like low body temperature, which is a hallmark of hypothyroidism.
Yes.
Right? Yep. And we never, ever, ever get people right once they've had a thyroidectomy.
No.
We just don't get them right. And anyone who says they are with Synthroid is lying.
Yes.
I'm sorry.
Yeah. Yeah.
They're lying.
Yes.
So,
even the very best doctors working on the thyroid balance still struggle to keep that balance, even if you get it temporarily, whether you're adding in other things, you're adding in T3, you're adding whatever you're doing, it still is never the same.
Never. And quite frankly, I mean, women have enough problems and struggle enough with metabolic health with intact thyroids.
Yeah.
So
yes.
Believe you me, it's even harder when you're trying to do it without a thyroid.
Yeah.
Right? So as it turns out, like the breast is related to all of this because the thyroid gland is completely dependent on iodine. So too is the breast. That has a lot to do with why both of them have dysfunction. And Dr. David Brownstein writes a lot about iodine and its relationship to both breast and thyroid disease. And then hypothermia has a lot to do with breast cancer. And so, that is again how they're related. But with regard to the breast and overdiagnosis, like there's I don't remember what year the study was, but there was a study on women who died of completely unrelated breast cancer causes. So they died of overdoses, or they died in car accidents, or some cause of death that had nothing at all to do with breast cancer, right? And they did autopsies on these 100 women. Do you know how many of them had microscopic evidence of breast disease?
25%? Wow, I guessed that. Wow. Okay.
Yeah.
So what do we take away from that?
So they had 20 DCIS diagnoses and 5 invasive cancer diagnoses.
So 5 out of 100, did you say? Is that the number?
Mm-hmm.
Wow.
Yeah.
Okay, we're way over treating. What I was really aware of when I left the surgeon's office that day, who, by the way, said to me, I said, I'm choosing to actively surveil this until it shows me. Because I said, what's the percentage likelihood that this is cancerous? And she said about 10%.
Mm-hmm.
And I said, that's not good enough for you to take my thyroid out. So until you can show me that it is actually cancer, we're not going there. And I said, I want to actively surveil. And she said, that's fine. I said, do you think I'm nuts? And she said, absolutely not. That is a totally reasonable way to monitor this. But if it was up to her intern and every other scared woman who has heard the cancer word from her GP or a nurse practitioner or the report on the biopsy, is just like, get it out, get it out, get it out, get it out. So we panic. This is what we do with our breasts, with our ovaries, with our uterus, with our thyroid. I'm tired of it.
I know.
I'm so mad about it.
You know, had you agreed with the intern, she would have just come in and consent you for surgery, and that would have been it. There wouldn't have been any further conversation. And I'm reminded when you talked about that statistic of 10%, when we use mammogram as the screening tool, and it leads to biopsy, 80% of the biopsies that are done have benign pathology. 80%. Which means that when we tell women that they need a biopsy because we're worried about cancer, we're only right 20% of the time. Can you imagine if you were only right 20% of the time? If I was only right 20% of the time? If the weatherman were only right 20% of the time? If your GPS was only right 20% of the time?
Oh my God.
Can you imagine? And yet we allow for this. We accept this. And when we look at the big mammogram studies, the Swedish trials, the Canadian breast cancer screening study, they all find the same thing, that when you compare, and we're talking about hundreds of thousands of women, and we're talking about systems that have universal health care, so everyone has the same access to care, everyone gets the same care. There's really no variables. Mm-hmm. Other than who gets screened with mammogram and who doesn't. And when you look at the numbers, like the exact same number of women die of breast cancer in both groups. And the only difference between the group that screens with mammogram and the group that doesn't is that there is somewhere between 20 to 30% more diagnoses of breast cancer in the group that screens with mammogram. And that tracks with that autopsy study that I was talking about, in that when you're looking for disease, you're going to find it.
Find it. Yeah.
And the harder you look, the more you're going to find.
Yeah.
So when we keep putting lipstick on this mammogram pig, we're gonna find more and more. And that is true of all those other diseases that we talked about, of thyroid disease. The harder you look, the more you're going to find. Mm-hmm. We're going to have thyroid dysfunction. It doesn't mean that we need to take the thyroid gland out. It means that we need to talk to people about their vitamin D, about their iodine intake, about their zinc, about their selenium, about their iron. Like, we need to talk to people. We need to monitor them. We need to see what their gut health is like. We need to make sure that they're getting out into sunshine, that they're managing their stress, that they don't have occult infections. The same conversations that I'm having with women about their breast health, right? Mm-hmm. We need to be talking way more about how to prevent or how to reverse something that's in its infancy than we do about rushing people off to surgery and radiation and drugs, because that story doesn't end well. Mm-hmm. And when we talk specifically about DCIS, ductal carcinoma in situ, we're taking a condition that, first of all, isn't cancer. And it's interesting. I just went down a little chat GPT rabbit hole.
Yeah.
Because I was like, well, let's see what it has to say about the other things, because people get really irate when I say that DCIS is not cancer. They get really irate. There's some lunatic of a radiologist who's reporting me to the medical board because she says that I'm dangerous or irresponsible. I'm going to kill people because I call DCIS. I don't call DCIS cancer. Story for another day.
Yeah.
So I said to ChatGPT, is cervical intraepithelial neoplasia cervical cancer? Because that's the the same diagnosis, the compatible diagnosis in the cervix to DCIS, right? So is cervical intraepithelial neoplasia cervical cancer? No. Okay. Is lobular carcinoma in situ breast cancer? No. Is ductal carcinoma in situ breast cancer? No, it's not invasive breast cancer, but it is precancerous. So didn't give me the whole bullshit explanation that when I asked about the other conditions, but because I struck a nerve, right? Because the system is saying, yes, it is. Because if the system says, no, it's not, then people pause and they say, well, I'm not going to take
my breasts off.
My surgery. I'm not going to have my breasts removed. Yep. I'm not going to take that medicine that is carcinogenic. I'm not going to take that medicine that can potentially give me osteoporosis or heart disease or dementia or right? I'm going to think twice about that if it's not cancer. I'm not going to rush into making a decision if it's not cancer. So it's a very inconvenient truth for the system that it's not cancer. And so they just yell louder, right?
Yeah,
They're the bullies. They're the bullies in the schoolyard.
Yeah.
And so here I am saying it's not cancer because it's not. And cancer is something that people die of, and no one dies of DCIS. And if you have someone that died of DCIS, you missed the invasive cancer.
Yeah.
So it could have been an and, but they did not die of DCIS because no one dies of DCIS. It's impossible to die of DCIS. DCIS, by definition, is confined to the ducts. The only way breast cancer is fatal is if it spreads to some other area of the body, some other vital organ, right? It's got to spread to the brain or to the lungs or to the liver, some other vital organ. People don't even die of bone metastasis. They die of metastasis to vital organs, and the only way that it can spread to vital organs is it has to get into the bloodstream or get into the lymphatics. Well, both of those structures live outside of the ducts. So there's no way for the cells that are lining the ducts to get into the bloodstream, to get into the lymphatics. There's just no way. Yeah. And so no one dies of DCIS. But if you treat them for DCIS with surgery, with radiation, with drugs, then you make them vulnerable to the diseases that are the side effects of those drugs. And this is the conversation that women are not being given. They're not having these conversations before they sign up for 5 years of these drugs or for radiation. Radiation does not improve survival. Does not improve survival. Even when we're talking about invasive cancer, radiation does not improve survival. And yet, we're telling every single woman who has a lumpectomy that she should have radiation. Why?
Yeah.
Why? Yeah. Why are we telling them that?
Ask the question, why? Get in there, dig in there.
And again, why I wrote my book. So that people, in every single scenario, I have 20 questions for you to ask your doctor before you say yes. And I am not saying that no one should be treated for breast cancer. I'm not saying that breast cancer isn't a horrible disease. It is. I'm not saying that no one should do conventional treatments. Everyone should do what resonates with them. And there are some people who have such tremendous tumor burden that I think they should have some conventional treatments, right? If your proverbial bucket is overflowing, if your proverbial sink is overflowing, you got to clean up that mess, right?
Mm-hmm.
And surgery and chemo and radiation, they're the mop for the floor. But the far more important thing that you need to do is turn off that faucet.
Mm-hmm.
So for me, the functional medicine side of it or integrative medicine side of it or whatever you want to call it, that's the end, right? And you have to do that part. But it's okay if you need the other part. It's not a weakness and there's no judgment. Like everyone should get what they need, but you should know what all of your options are. And you should have the ability to choose. And you should also have the ability to say no.
If you're anything like me, moving through midlife means bringing a few nagging issues, especially around digestion. Maybe it's bloating after meals, new food sensitivities, or just that sense that your gut isn't as strong or resilient as it used to be. On this podcast, we talk a lot about midlife things like hormones and managing stress, but symptoms like fatigue, brain fog, and immune flare-ups often trace back to one place: your gut lining. Science shows that many common digestive issues stem from a compromised gut barrier, also known as intestinal hyperpermeability. When those tight junctions between cells loosen, unwanted food particles slip through, triggering inflammation and immune stress. That's where the trouble begins. That's why I want to introduce you to Ultimate GI Repair by Level Up Health. This isn't just another probiotic. It's advanced, natural gut healing at its finest. It's designed to restore gut integrity right at the source. What makes it so unique is its peptide-powered gut support, a blend of 4 purified, clinically dosed peptides. The first is BPC 157 for deep tissue repair, larazotide to reinforce tight junctions, KPV tripeptide to calm inflammation and modulate immunity, and GHKCU to support matrix remodeling and systemic healing. This is true peptide synergy, and it works really well. It doesn't stop there. Ultimate GI Repair also includes zinc L-carnosine to stabilize mucosal surfaces, Tributrin, a bioavailable form of butyric acid to fuel intestinal cells, and buffered sodium bicarbonate to protect peptides from stomach acid and enhance absorption. Whether you're recovering from stress or travel or just want long-term digestive support, this formula is comprehensive, hypoallergenic, and third-party verified. Ready to give your gut the advanced support it deserves? Visit leveluphealth.com and use the code LOVELY at checkout to save 15% site-wise. Again, that's LVLUP code LOVELY. You know what I hear from so many of you? I wish I'd known. I wish someone had told me. I felt so alone. What if no woman ever had to say those words again about menopause? The menopause doula certification isn't just about training women to help women. It's about building a community of advocates who refuse to let women navigate menopause in isolation and confusion. Whether you're a therapist, a nurse, a wellness coach, an allied health professional, or simply someone who's passionate about supporting women, this certification will give you the tools to make a real difference. We're talking comprehensive training in hormone health, brain science, sexual wellness, emotional support, everything you need to truly understand and support women through this transition. But more than that, you'll join a movement of people who believe that menopause deserves expert, compassionate care, that women at midlife deserve to be seen, heard, and supported. Are you ready to be part of the change? I'd love to see you there. Visit menopausedoulasociety.com and let's do this.
And I just heard this horrible story the other day, because getting back to screening and what I do for screening, because I talk to people about doing physical examination and doing that ARIA tears test.
Mm-hmm.
But if you need imaging, I don't believe in putting healthy women at risk. I don't believe in putting them in harm's way. I don't think that we should encounter or assume any risk when we're screening for breast cancer. So I talk to people about the QT scan, which is what we have at Perfection Imaging, or I talk to them about ultrasound. So there was a woman who came to our center, and she came to our center after she asked her provider for an ultrasound to screen. And her provider said, no, you need a mammogram. And she said, I don't want to have a mammogram. And if I don't have an ultrasound, then I'm just not going to screen. Right. And this is the choice that we are making women make. We're not allowing them to just screen with something that's safe. We are saying you have to have a mammogram. And in this country, most women can't get an ultrasound paid for by their insurance unless they have a mammogram first, which is terrible. Like, we are not given a choice. So this woman, her doctor gave her a prescription for a mammogram and a prescription for an ultrasound and said, you schedule them both and, see if they'll let you do it. And so she scheduled them both, but didn't go for the mammogram appointment, only went for the ultrasound appointment. Mm-hmm. And they refused to do the ultrasound, and they actually barricaded her into the thing and said, you have to have a mammogram. And she's like, no, I'm leaving. And yeah. Like, wow. Can you imagine? And I'm just reminded of that Shakespeare quote, methinks thou dost protest too much.
Too much. Yes.
Right? Like, yes. You have to start to ask the question, why are they screaming?
Yeah.
What are they so afraid to debate that they're screaming? Because they're screaming.
We are living in a strange time.
I'm not screaming. I'm perfectly calm.
Yeah.
Right? Debate me.
Yeah.
Let's talk about it.
Let's talk about
the data, because the data is very clear. There is no survival benefit to screening with mammogram. There has never, ever been a survival benefit demonstrated. Never.
Can you imagine if the powers that be just went, okay, I guess this mammogram thing is wrong. We'll just shut them down. Can you?
So this is what they're afraid of. It's just so hard to say,
oops. And yet it's just another place that women are being gaslit, disregarded, mishandled.
I'm reminded of the Upton Sinclair quote. Do you know this one?
No, where start talking. Maybe I've heard it.
I may not get it exactly right, but this is the gist of it. It is impossible to teach a man something when his livelihood depends on him not knowing it.
Oh, Jesus.
And that's where we are.
Yeah.
Right? That's where we are. That mammogram is a multi-billion-dollar industry.
Yeah.
They are not going to lay down the gauntlet. They're just not.
No.
They're not going to go away so fast. But this is what's going to make them go away. And I'm not even talking about getting rid of them. I'm just saying we shouldn't be using it for screening. If we need it for diagnostic purposes, we need it for diagnostic purposes. And until we can agree across the board and speak a mutual language, like, I'm not saying it should go away overnight, but I'm saying we should not be using it for screening. We should not be putting healthy women in harm's way, especially when there's no survival benefit.
Yeah. Wow.
Right?
Wow.
And so I think it's going to take me 5 years to really change screening paradigm, but I'm doing it. I mean, I reach millions of people every month. So they know my name. They know my voice. I'm definitely a threat to the status quo. It's very, very scary to the people who have been doing it their whole lives. And, this isn't about me saying I told you so. Like, let's just move on.
Yes.
And move forward and embrace the future with hope and promise. But this movement is going to come from the women because the system is not eager to change. No. And I get it, right? It's impossible to teach a man something when his livelihood depends on him not knowing it.
Oh, that's so powerful. And I think it's also very helpful for women to understand that that's where their doctors are coming from, whether it's, and I always say, it's not about bad doctors, although I'm sure they're out there. It's about the system y'all are trained in. That's the problem.
Yeah, that's it. We have very good doctors. Dr. Erica Schwartz she wrote a book about this. I have to memorize what her book is called, but Dr. Erica Schwartz wrote a book that essentially says you have very good doctors with very bad training. And that's it. That's the bottom line. We have very good providers with very bad training.
And so there's forgiveness and compassion all the way around. Now, listen, I can say that because I knew enough not to have my thyroid whipped out. I know enough not to have my breasts taken off or my uterus removed. But by far, most women don't know that, although we're waking up. We're waking up.
Yeah.
So as you said, it's going to come from us. The revolution will come from us. The powers that be, I've been having this conversation a great deal lately. The powers that be think we're getting all frail and neurodegenerative over here. We're getting all strong and all proteined up and we're getting rid of the inflammation, dropping weight like crazy. I mean, look out. We ride at dawn.
Yep. Oh, I love that. We ride at dawn. I'm going to use that. Can I use that?
Please do.
Okay.
Please do.
I love that. We ride
make sure you include me.
I just got chills. I will.
Yes.
I for sure will. Yeah. I mean, we didn't even get into the hormone conversation, which, that's another one where after 20 years, we still have thousands and thousands and thousands of practitioners who still believe that hormones cause breast cancer, despite the fact that that study has been retracted, despite the fact that we have evidence otherwise, right? And so, and it's not as if when you look at the data, when hormone replacement basically plummeted after 2003 when that study was released. And we've had nothing but an increase in breast cancer since then.
Yeah. Hello.
Right? Like if hormones were the problem, why didn't it help to stop them?
Exactly. And it was you who taught me that women who actually experience breast cancer when on hormones have better outcomes.
Better outcomes across the board. And that's because, well, I think it's twofold. First of all, women who are on hormones have less of the other diseases. So less cardiovascular disease, less neurodegenerative disease, less osteoporosis, and all the secondary things that make life worth living, right? And then when we look at women who got breast cancer and took hormones afterwards, no increase in recurrence, no increase in death from breast cancer, and better quality of life, less dementia, less cardiovascular disease, less everything.
Everything.
Right?
Yeah.
And so the people that work in the space, we have no question, and yet there's still so much fear-mongering out there about breast cancer and hormones. And it's all because we were told this very oversimplified, ridiculous narrative that sounds like, oh, you have ER positive breast cancer. We're going to put you on an ER blocker and that is going to be your treatment. And no one says, and you're going to be miserable and depressed, and you're not going to sleep, and everything's going to hurt, and your relationship is going to suffer. Your quality of life is going to suffer. You're going to need pharmaceutical after pharmaceutical after pharmaceutical. Like, no one talks about that part. They just talk about be grateful to be alive.
I was just going to say, you be
Right?
grateful to be alive. You don't bring up those things.
Yeah.
Absolutely.
So, I'm out there talking about the safety of bioidentical hormone replacement after breast cancer. And I encourage people to read books like Estrogen Matters by Avram Blooming, to read Bioidentical Hormones by Dr. Jeffrey Dash, to read Happy Healthy Hormones by Dr. David Rosensweet. I mean, there's really good books out there by people like me in the trenches doing it every day. So don't tell me that there's increased risk. If there's increased risk, where is it?
Yeah.
My population should, if there's increased risk, my population should show it. Now, are my ladies special? For sure. Because my ladies aren't just getting hormone prescriptions. My ladies are being talked to about what to eat, when to eat, how to eat, what to drink, how to move, how to think, how to detox, how to sleep. Like, I'm talking about all the things that everyone should be talking about, because everyone should be living their life like they failed the test. Just so happens that my ladies failed the test, right?
Yeah. Yeah.
But
at least they have you.
If you live your life differently after your diagnosis than you lived your life before your diagnosis, you're going to know a different version of you. And by and large, this is going to be a better version of you. If you're doing the things, you're going to know health probably better than you knew it ever in your life.
Yeah.
Ever.
Yeah.
And people often don't realize that they weren't healthy. I didn't realize I wasn't healthy until these things are pointed out.
Yeah.
Until we talk about all of the causes of breast cancer. And they're like, oh, yeah.
Yeah.
Like, I thought I was healthy.
Yep.
And then you taught me all of this.
Yes. Yeah. What a gift.
And so, I have a program for women who have a breast cancer diagnosis. Either they're just diagnosed, or they're in treatment, or they completed treatment and they're wondering now what, or, they were treated years ago and they're worried about recurrence. So I have something called the Breast Health Blueprint, where we give women all of these foundational tools to their health, and also a lot of personalization. But there are foundational things that everyone can do to improve their health. And what we all have to remember at the end of the day is breast health is health. And the very same things that you're going to do to improve your breast health are also going to improve your heart health, your gut health, your brain health, your bone health, your urogenital health, everything.
Yes.
Everything. Because breast health is health.
Yeah, I love that. As always, you dug right in there. I love this. Each time we meet, like, the conversation is just like, okay, we're in. Like, we're just in. We're just talking. Yeah. There's not even any questions. I don't know why I make questions, to be honest.
I don't know why either.
You gotta stop, because although here's what we're going to talk about. First of all, thank you. And would you come on the show in 2026, please?
Of course.
Yay!
Of course.
Good, because I learned so much. But you started to talk about the ER receptor, I made some notes this morning, the estrogen progesterone receptor positive, the HER2 status, the BRCA gene, the mutations. We need to talk about all of that, because a lot of it is just people not really understanding what they're looking at, and doctors saying, no, that means you can't ever do HRT. So that's what we'll talk about next time. Is that okay with you?
All right. And if people want the answers in the interim, please read my book, The Smart Woman's Guide to Breast Cancer. My next book, which will probably not come out till 2027 because I don't have time to write it, but it is entitled The Forgotten Woman, which is all about that woman who was treated for breast cancer and told that she should be grateful to be alive. But it's very hard to feel grateful when you have brain fog and headaches and you can't sleep and you've gained weight and your body is deformed and your breasts are absent and, all the things that go along with breast cancer. But I give these women a new lease on life, because you don't have to conform to that and you don't have to accept that. I think that how we leave most women after breast cancer is unacceptable. We need to stop villainizing estrogen. Estrogen is not our enemy. Estrogen is the hormone of life, and we all need to embrace that. Mm-hmm. So you really need to understand that estrogen positive breast cancer is a variation of normal. The breast cancer part is the abnormal part, but cancer is a normal response to an abnormal environment. And most women who get breast cancer are estrogen deficient. Breast cancer is a disease of hormone deficiency, not excess.
Not to mention iodine deficiency, which we will dig into next time too.
So we'll talk about all of that next time. But like,
do we wait a year?
All I have to say is, if it doesn't make sense, it's because it's not true.
Yes. Yes. Use your instinct, use your gut.
And we just need to, I always said to all of my medical students and my residents and my fellows that I've trained over the years, like, medicine is logical. And when it doesn't make sense to you, it's because it's wrong.
Yeah.
Right? Like the whole, I'll just go back to mammogram one more time. In every other instance, when you ask a radiologist, when you ask anyone, does radiation cause cancer? The answer is a resounding yes.
Yeah.
Do mammograms cause cancer? Absolutely not. How can they both be true? How can both statements be true?
Yeah.
Right?
Yeah, they
can't.
Yeah.
And don't tell me that it's a low dose, and don't tell me that it's the same as flying cross country, because I'm calling bullshit on that.
Yes.
Right? When you fly cross country, that is scattered radiation.
Yeah.
Which does not have the same potential to do damage as the focused cone down radiation that you get during a mammogram.
Right.
So,
into the
everyone just ask yourself, does this make sense? And if it doesn't make sense, if it's not logical, it's because it's not true.
Yeah.
And when we talk about hormone positive breast cancer, you should all know that when you look at a normal breast cell, it has estrogen receptors on it. Mm-hmm. It has progesterone receptors on it. It has HER2 receptors on it.
Mm-hmm. That's right? A normal breast cell, guys.
A normal breast cell.
Yeah.
So now, do the cancer cells have more of those receptors? Yes. That's a survival mechanism because you don't have enough hormones. So it's looking for it to survive.
Yeah.
Right?
Yeah.
It is all, cancer is just a survival mechanism. So if we create an environment that is not threatening, cancer goes away.
Wow. That's so powerful. I have so much to unpack after this conversation, as always. Okay. And you and I can talk forever. Yes. Let's see what we can come up with next. I mean, that whole Ride at Dawn thing, you just call me. I'll bring my people.
Ride at Dawn. We'll ride at dawn.
I know. Where can people find out more about you, please?
So my medical practice, for anyone who's looking for assistance along their breast cancer journey, is called Real Health MD. And you can listen to me on my podcast, which is Keeping Abreast with Dr. Jenn. If you want to have one of the QT scans, which is the imaging that I advocate for, which uses sound waves transmitted through a warm water bath. So it's like a spa day for your breast, but you come out on the other side of it with a 3D reconstruction of the breast. And so it's very sensitive and very specific, and all the while, no radiation, no compression, no pain, no trauma. So that's Perfection Imaging, PERFEQTION, imaging.com. And then you can find me on all the social channels. I'm at Dr. Jenn Simmons, and my Jen has 2 N's. And then if you're looking for my book, The Smart Woman's Guide to Breast Cancer, you can find that on Amazon.
Amazing.
Or on my website, realhealthmd.com.
Yes, perfect. So many resources. Thank you for sharing. And I know I've asked you this question before. This is the final question I ask all my guests, but as our wisdom evolves, I'd be interested to hear how things change for you. And I do not remember what you said before, so you're all good.
Okay.
Knowing what you know now, what would you tell your younger self?
Oh, wow. Wow. I think that I would have told my younger self to be more disciplined in high school. I think I would have had a clearer path to medical school, and because I ended up taking a lot of time in between. I wish that I had gotten started a little earlier so that maybe I could have made my evolution a little earlier. And at this point, I would have gotten rid of mammograms earlier. Like, I just wish that I had focused a little younger. I didn't finish medical school until I was 30 years old.
Yeah.
So
I like that.
just maybe a little more of enlightenment, a little more focus, a little earlier in life.
I like it.
I didn't realize I was a student until I was 25.
Right. Just in time for med school.
Yeah.
As always, thanks for coming on the show. And I'm so grateful to know you and to be the place that you will share this information. There's so many women that will be helped by what you've shared vulnerably today. Thank you.
Thank you. Thank you for having me. It's always wonderful to see your beautiful smiling face. And I always look forward to our time together. So thank you for having me.
Thank you. The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.